Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module we are going to deal about the premature menopause, which is also termed as primary ovarian insufficiency. So when we were discussing about menopause, I told you about this premature menopause. So this premature menopause has recently been termed as primary ovarian insufficiency, and this topic is much of practical significance, so I have curated this as a separate module for you. So what is primary ovarian insufficiency or premature menopause? So any female who has been previously menstruating normally, if she is going to attain menopause at less than 40 years of age, the most probable reason due to ovarian failure, she can be termed as a case of premature menopause, which is also termed as primary ovarian insufficiency. So I'm just repeating the definition. So any female who has been previously menstruating normally and she has attained menopause at less than 40 years of age due to ovarian failure, she can be termed as a case of premature menopause or primary ovarian insufficiency. See, the most common cause for this premature menopause is ovarian failure. So since the ovary has failed, it is called as ovarian insufficiency. Primary ovarian insufficiency is also called as premature menopause. Okay, so as we all know, what is the normal age for the attainment of menopause? So the normal age for attainment of menopause in Indian females is around 47 years. But we also need to tell in terms of variables, right? We can't be very sure about the age where a female will attain menopause. You need to give a variable that you can't tell an examiner that the menopause occurs in Indian females at 47 years. No, it is not like that, because she can attain menopause 2 years earlier or 2 years later also. So you always need to give a variable. So it is between 47 to 51 years, which is a normal age for attainment of menopause in Indian females. So if they give you like single number in the option, it is 47 years. But if they are going to give you a variable, it is between 47 to 51 years. So as I discussed earlier, the most common cause for this primary ovarian insufficiency is ovarian failure. So as you can see here, so this is the normal ovary and this is the ovary which has been insufficient. The reason is that in a normal ovary, there are multiple ovarian follicles which are present in the ovary. And during each cycle, there is going to be apoptosis of these multiple ovarian follicles. Their ovary follicles is going to undergo atresia, and only few follicles are going to mature and release during ovulation. So as you can see here, this is the maturation of the ovarian follicle. It is undergoing various stages, and finally ovulation is happening and mature ovum is getting released from the ovary. But if you see in the ovary of a premature menopause female, there are no ovarian follicles are left over. See, as I told you earlier, the number of ovarian follicles in a female is actually predefined, and starting from the puberty after also, the female is going to undergo menstrual cycle every single month, and during each of the menstrual cycle, the ovarian follicles are going to undergo atresia, where the number of ovarian follicle is going to decrease significantly in each of the menstrual cycle. And once all of these ovarian follicles are become atretic, then the ovary will be left with no ovarian follicles. So when there are no more ovarian follicles, then the ovarian follicles cannot mature and it can never be released as a mature ovum. So since because of insufficiency of the ovarian follicles in the ovary, the patient has attained menopause. So therefore the most common cause for this premature menopause is ovarian failure, because of absence of ovarian follicles, because of atresia which is happening in a very hastened manner. So the most common cause for premature menopause is ovarian failure. Is that clear? Okay, so now let's get inside what are the causes of premature ovarian failure. So I just want you to take a screenshot of this, right? So this is very important, so this might be very helpful for you in your examinations. The number one cause is that the number of ovarian follicles at birth is insufficient. See, I told you that the number of ovarian follicles is maximum at around 5th month of the intrauterine life, where it is around 6 to 7 million ovarian follicles. And by the time the female fetus is going to born, the number of follicles is going to decrease even further, right? It is going to decrease even further, and around the time of puberty also, the number of ovarian follicles in the ovary is going to decrease. But in cases where even at the birth, the number of ovarian follicles are very limited and insufficient, in such females, ovarian insufficiency is anticipated to occur at a much earlier age than the curated age between 47 to 51 years. Am I right? See, 1 to 2 million follicles are present at birth. 1 to 2 million ovarian follicles are present in the ovary of the female fetus at birth. So this happens in every normal single female fetus. But if the number of ovarian follicles in the ovary of the female fetus at birth is going to be decreased, let's say for example, instead of 1 to 2 million, it is only 4 lakhs or 5 lakhs, because of this insufficiency of the ovarian follicles, soon after she attains the puberty and she is going to experience the atresia of the ovarian follicles every single month during her menstrual cycle. Since the number of ovarian follicles is limited, since the atresia is going to happen every single month, then all these ovarian follicles will get depleted very soon than where it is anticipated normally, which is between 47 to 51 years. So since the number of ovarian follicles at birth itself is insufficient, therefore the premature menopause is anticipated to occur at a much earlier age than the normal age for attainment of menopause. Is that clear? So the number of ovarian follicles at birth is insufficient. So this is the first cause. The second cause is that the follicular atresia is accelerated in the ovary. So what are the causes where the atresia of the ovarian follicle is going to get accelerated? The cause could be something like administration of chemotherapeutic drugs to the patient in treatment of any cancer, or administration of radiation therapy, to be more specific, radiation to the pelvis, right? All these causes could lead to hastened atresia of the ovarian follicles in the ovary. Since the ovarian follicles are going to undergo atresia in a very hastened and accelerated manner, therefore the female might end up in primary ovarian insufficiency much earlier. The most important question here is, the most sensitive pelvic organ in radiation exposure is ovary. So ovary is the most sensitive pelvic organ in radiation exposure. So in any patient with history of pelvic irradiation, you have to think about the ovarian failure, because ovarian failure occurs most commonly in patients with history of pelvic irradiation. So in patients of radiation therapy or chemotherapeutic drugs, follicular atresia is anticipated to occur in an accelerated manner, which will result in ovarian failure, and the patient is going to attain menopause at a much earlier age than the normal age. Clear? Yes. And the third cause is that the ovaries are dysfunctional at birth. At birth itself, the ovaries are dysfunctional. See, normally the ovaries are not dysfunctional at birth, right? Because the ovary is going to contain the number of ovarian follicles, 1 to 2 million. But then, in these patients, the female fetus, when they are born itself, the ovaries are dysfunctional. What are the most common causes? It could be Turner syndrome, where there is absence of one of the X chromosome. So because the karyotype is 45XO, because of the absence of one X chromosome, the ovaries are streak underdeveloped ovaries. So since the ovaries are dysfunctional right at the birth, therefore this ovary cannot be functional and it cannot ovulate, it cannot release any mature ovum. So this is the cause of primary ovarian insufficiency. So Turner syndrome. Now, the second cause for dysfunctional ovaries could be fragile X syndrome. So fragile X syndrome is a syndrome which is caused by pre-mutations in the FMR1 gene. So because of this pre-mutation which happens in the FMR1 gene, there is going to be CGG triplet repeat within the FMR1 gene. Because of this triple repeats within the FMR1 gene, this patient is going to have fragile X syndrome. See, the normal number of repeats is between 5 to 20. But in patients of fragile X syndrome, the triplet repeat within the FMR1 gene is somewhere around 55 to 200. So because of the CGG triple triplets, repeats within the FMR1 gene, the patient is going to result in a syndrome called as Fragile X syndrome. So Fragile X syndrome is caused by pre-mutations in the FMR1 gene. So because of this pre-mutations which happens in the FMR1 gene, there is going to be CGG repeat triplet within the FMR1 gene. So because of this repeats, which is around 55 to 200 times, the patient is going to have this Fragile X syndrome. So what are the features of Fragile X syndrome? The features are the fetus is going to have intellectual disability, autism spectrum disorders, and the most important features is primary ovarian insufficiency. The female fetus, once after born, it is going to have some intellectual disability, autism spectrum disorders, and primary ovarian insufficiency. So primary ovarian insufficiency happens in Fragile X syndrome. Clear? So in Turner syndrome, the ovaries are streak ovaries, and in Fragile syndrome, because of the triplet repeats within the FMR1 gene, the patient is going to have Fragile X syndrome because of this triplet repeat. So the patient will be having features such as intellectual disability, autism spectrum disorders, and primary ovarian insufficiency. Clear? Yes. The third most important syndrome is Perrault syndrome. Perrault syndrome is an autosomal recessive inheritance syndrome. Okay, the features of Perrault syndrome are bilateral sensory neural hearing loss, neurological dysfunction, and ovarian dysfunction. So ovarian dysfunction is a feature of this Perrault syndrome. See, it will take much time to discuss about each of this syndrome. The only important point we need here is what are those syndromes which is going to result in dysfunctional ovaries. So the first syndrome was Turner syndrome, where the ovaries were streak ovaries. The second syndrome was Fragile X syndrome. Because of the CGG triplet repeats within the FMR1 gene, the features are intellectual disability, autism spectrum disorders, and primary ovarian insufficiency. In Perrault syndrome, which is inherited in an autosomal recessive pattern, the features are bilateral sensory neural hearing loss, neurological dysfunction, and ovarian dysfunction. So because of this ovarian dysfunction, the patient is going to have primary ovarian insufficiency. And the fourth important is 17 alpha hydroxylase deficiency. So 17 alpha hydroxylase is an enzyme which is the most important enzyme in production of the glucocorticoids, mineralocorticoids, and the sex hormones. So because of deficiency of the 17 alpha hydroxylase, there is going to be decreased glucocorticoid, mineralocorticoid, and the sex hormones. So therefore the aldosterone is decreased, the cortisol is decreased, and therefore the estrogen estradiol level is also decreased because of this enzyme deficiency. Right? Now you may have this doubt that why decrease in levels of estradiol is going to cause this primary ovarian insufficiency. The reason is that we all know that for proper ovulation to happen, LH surge has to happen 36 hours before the ovulation. Only if LH surge is going to happen, approximately about 36 hours after the LH surge, ovulation is going to happen. But in this patients of 17 alpha hydroxylase deficiency, the levels of estradiol are decreased in this patient. But we also know that only when the levels of estrogens are increased for a period of about 48 hours, only then LH surge will happen. But in this patients, estrogen will never be increased for 48 hours. So when the estrogen is not increased for 48 hours, therefore no LH surge is going to happen. If no LH surge is going to happen, after 36 hours, no ovulation is going to happen. If no ovulation is going to happen, therefore the number of mature ovarian follicle is going to be decreased. So this might result in primary ovarian insufficiency. Is that clear? Right? Estradiol is important for LH surge. LH surge is important for ovulation. If all this is going to decrease, because estrogen is very important for follicular development, therefore the follicle will never develop and it will undergo atresia. Therefore the ovary is going to be dysfunctional ovaries because of accelerated atresia and because of absence of ovulation. Clear? Yes. Now, the fourth most important cause could be some autoimmune disorders. So what are autoimmune disorders? Autoimmune disorders are the disorders where the body is going to produce some antibodies which is going to attack the body itself. So the body is mistakenly attacking own self. So there are more important autoimmune disorders such as hypothyroidism, Hashimoto thyroiditis, Graves' disease and Addison's disease. So all these are autoimmune disorders. So similar fashion as an autoimmune disorder, if the patient is going to have, there could be chances that the body is going to attack its own ovary, which will result in primary ovarian insufficiency. Right? Clear. The fifth cause is viral infections. So viral infections such as mumps. Mumps is going to cause mumps ophoritis. What is ophoritis? Inflammation of the ovaries. Because of infection, there is going to be inflammation of the ovaries. So because of mumps ophoritis, there could be chances of ovarian failure. But most of the patients are going to recover significantly after the recovery period. But there could be chances of ovarian failure in patients of mumps viral infections. Now, the sixth most important cause is laparoscopic ovarian drilling. Laparoscopic ovarian drilling. Do you remember laparoscopic ovarian drilling, which we discussed in PCOS treatment, right? So laparoscopic ovarian drilling is when we are actually going to destroy the theca cells of the ovary. So once the theca cells of the ovary is going to be destroyed, there is going to be decrease in levels of androgens being produced from the ovaries. Is that clear? So when you're going to perform this procedure of laparoscopic ovarian drilling, there are increased chances of ovarian failure. I have told you in that module that in laparoscopic ovarian drilling, the disadvantage could be ovarian failure. So in patients where laparoscopic ovarian drilling has been done, there are chances of ovarian failure. So certain patients might end up in primary ovarian insufficiency, that is ovarian failure due to laparoscopic ovarian drilling. So laparoscopic ovarian drilling is also a cause of primary ovarian insufficiency. Is that clear? Yes. Now we are moving on to the investigations. So the investigation is basically to check the ovarian reserve. So as we know that primary ovarian insufficiency is all about decreased ovarian reserve. If the ovarian reserve, that is the number of the ovarian follicles, are going to be decreased, therefore the levels of estrogen which is being produced by the ovarian follicles are going to be decreased, right? Estrogen is produced by the granulosa cells of the ovarian follicles. So when the number of ovarian follicles are decreased, therefore estrogen is going to decrease. And we all know that estrogen has a negative feedback on FSH. But if the levels of estrogen is going to decrease, the negative feedback which estrogen had on FSH is going to be lost and FSH levels are going to increase. So therefore, the serum follicular stimulating hormone is going to be increased. So when serum follicular stimulating hormone is more than 40 international units, it is directing us towards the diagnosis of primary ovarian insufficiency. So serum FSH levels more than 40 international units, it is directing us towards the diagnosis of primary ovarian insufficiency. So it is one of the confirmatory tests. So the rule we have here is that just by a single measurement, you cannot be very sure that the female has attained primary ovarian insufficiency. No. You have to do 2 measurements, and these 2 measurements has to be done at least 1 month apart. So 2 different months you have to do 2 single measurements, and if in both these measurements the levels of serum follicular stimulating hormone is going to be more than 40 international units, then it is a confirmatory test in diagnosis of primary ovarian insufficiency or premature menopause. And the second most important test is decrease in anti-Mullerian hormone. So anti-Mullerian hormones are basically produced by the immature antral follicles. If the anti-Mullerian hormone is decreased, which is less than 1 or even less than 0.5, it is directing us towards the diagnosis of primary ovarian insufficiency. Less than 1 is suggestive of primary ovarian insufficiency. Less than 0.5 is diagnostic of primary ovarian insufficiency in females who are less than 40 years of age. Clear? Yes. And fourth investigation could be karyotyping. Right? Karyotyping, because I told you that in patients whose ovaries are going to be dysfunctional, such as Turner syndrome, Fragile X syndrome, and then we also discussed about the 17-alpha hydroxylase deficiency and Perol syndrome. So in those syndromes, there will be some coexisting features present in that patient in terms of intellectual disability, autism spectrum disorders, difficulty in concentration, and etc. That's such as bilateral sensory neural hearing loss, some neurological dysfunction. So these coexisting features will be present in that patient. So if such coexisting features are present, you need to do karyotyping in order to rule out what genetic cause is being present in that patient, which leads to this primary ovarian insufficiency. So karyotyping is also an investigation. Okay, so now what are the basic symptoms the patient is going to experience? See, this is actually menopause, right? This is a menopause, but the only thing is that this menopause is going to occur at less than 40 years. So all the symptoms of menopause can occur in these females also. So in those females who are less than 40 years but have attained premature menopause, all the symptoms of menopause is going to be present in them. So initially, the patient will be experiencing irregular cycles. Subsequently, she is going to experience amenorrhea for a period of about 1 year. Clear? And then similar to a menopausal female, this premature menopausal female will also experience hot flashes because of decrease in estrogen, decrease in libido, senile vaginitis, genitourinary syndrome, and the most common symptom of osteoporosis, that is low backache as well. So in such osteoporotic female, you need to check the bone mineral density in order to check out whether the bone is osteoporotic or not. And you need to administer the management for this osteoporosis in that female. So all the symptoms of menopause can occur in females who have attained premature menopause as well, because the main problem is decrease in estrogen. When the levels of hormones is going to decrease, all such problems will start. So eventually the female is at increased risk of migraine, the female is at increased risk of the cardiovascular disease and cerebrovascular accident and everything. Clear? Yes. So now what is the treatment of choice? The treatment of choice is hormone replacement therapy. Why hormone replacement therapy? See, female hormones such as the estrogen are the most important hormones which is going to prevent the female from many comorbids the female is going to experience. Until 50 years of age, most of the Indian female are going to be apparently normal. Only after 50 years, they are going to experience symptoms such as hot flashes, dryness of the vagina, decrease in libido, low backache, such complaints. So all these complaints are actually happening because of decrease in estrogen levels. So a female was not at menopause. Estrogen is a protective hormone. Estrogen is going to protect from all such causes which is going to result in comorbids, such as it will decrease the risk of atherosclerosis, it will decrease the risk of cardiovascular disorders, etc. But once she is going to attain menopause, because of the lack of this protective hormone estrogen, the female is more prone to cardiovascular disorders, and she's at increased risk of atherosclerosis, migraine, and she might develop senile vaginitis, genitourinary syndrome, increased risk of UTI, low backache because of osteoporosis, and etc. So our major role is to just give this hormone from outside. So from outside you give this hormone until the natural age of menopause. So naturally a female will attain menopause around 47 to 51 years. But in patients of premature menopause, where menopause is attaining at less than 40 years, in a female at less than 40 years, you need to start giving hormone replacement therapy, that is HRT. And this HRT has to be given until 47 to 51 years of age, which is the natural age for attainment of menopause in Indian females. So if you're going to give this hormone replacement therapy till 47 to 51 years, these hormones are going to protect this female from increased risk of cancers, cardiovascular disorders, atherosclerosis, and it will prevent osteoporosis, senile vaginitis, hot flashes, genitourinary syndrome, decrease in libido, and as well. Is that clear? Right. So in this patient, you need to give both estrogen and progesterone. Why? Because uterus is present in this patient. If you're going to give only estrogen, it is going to result in endometrial hyperplasia followed by endometrial cancer. So for support of the endometrium, you have to administer progesterone along with estrogen in patients with intact uterus. So give estrogen and progesterone until the ideal age of menopause, that is 47 to 51 years. But also, in females who are complaining of low backache, in such females you have to check the serum vitamin D3 levels and calcium levels. If the levels of serum vitamin D3 and calcium levels are decreased, you need to start calcium and vitamin D3 supplementation in such females. Right? Clear. The most important rule here is that hormone replacement therapy is never given for female more than 60 years of age. See, ideally, it has been said that hormone replacement therapy is never given for female more than 60 years of age. More than 60 years of age, it is not required to give hormone replacement therapy. And the second most important point is that hormone replacement therapy should not be given for more than 5 years. For 5 years, you can give very well. But more than 5 years, use of hormone replacement therapy is not much indicated. So, for 40 years, a female is going to attain menopause in prematurely. You give hormone replacement therapy for 5 years. That is enough. After that, she will enter the perimenopausal age group and she will be in the ideal age of menopause. So you stop after 5 years. So the ideal age to give this hormone replacement therapy in patients of premature menopause is about 5 years, and hormone replacement therapy is never given for females more than 60 years of age. Clear? Yes. If a female who is less than 40 years of age, let's say for example she is 35 or 30 years of age, but she has complaints of infertility, she is desiring for fertility, what is the option which is available to you? Since there is ovarian failure in this patient, therefore there is no mature ovum available for us in the ovary. So you can use donor egg and you can do in vitro fertilization and you can transfer that embryo inside the uterus of this patient. Is that clear? The main problem with primary ovarian insufficiency or premature menopause is ovarian failure. Because of ovarian failure, there is no ovum left in the ovary. So get a donor egg from some other person according to the law, and then you can do in vitro fertilization where you're going to do artificial fertilization in the laboratory, and once the embryo is formed, you are going to transfer this formed embryo in the uterus of this female. So donor egg and in vitro fertilization cycles are done in patients who want to who is desiring to have a pregnancy or those who complains of infertility. Right? So I hope this topic is very interesting and we made it very simple here. So in case if you have any doubt regarding this topic, please write us in the Mackler Gmail handle so that I will reach out to you as early as been possible. If you have any queries regarding my teaching, if you want me to just correct, or if you want some extra points to be added, or if you want to elaborate it, or if you have any single doubt, you can write to us in the feedback session in the Mackler handles. Right? So please subscribe to this Mackler YouTube handle so that you will get daily